Uganda, I think, since it is when antibiotics were first introduced there. But to really come together as a group and express concern was in 2015. The lab team said we must do something. Let's document the burden, the magnitude of resistance, and we formed a national task force for AMR surveillance. That was followed by the situation analysis, similar to what was done in many other countries. And around that time, the Global Action Plan was also being formulated, and it was published. 2016 to 2018, we developed our National Action Plan, which was launched in 2018. 2020, we Surveillance Task Force gave way to our National Antimicrobial Resistance Subcommittee, which I currently chair. And our National Action Plan had the usual 5 strategic objectives in the Global Action Plan. So those were our strategic objectives in the National Action Plan. The National Action Plan is a One Health action plan. So One Healthness is actually emphasized in our National Action Plan. Coordination is by what we call the National One Health Platform. This platform has representation from the Ministry of Agriculture, and we developed a checklist to antimicrobial resistance. We've done this for human health, but we've not yet done it for the very other programs related to antimicrobial resistance. We've done this for human health, but we've not yet done it for the very other programs, and I think we shall soon ensure that the vet programs, the animal health programs also integrate this in their curricula. We came up with a better support for AMR activities from at national level because of this parliamentary forum. Engagement of youths in AMR activities. We established surveillance as the point of entry for various AMR interventions. And so surveillance, we consider it point of entry. We've developed frameworks for surveillance in human, animals, and the environment with various guidelines. Built microbiology capacity. At the beginning, around 2015, we had only a handful, maybe, I think it was about 4 laboratories in regional reference laboratories. This is in the 20 healthcare regions of the country. Only about 4 labs had the capacity to do microbiology. Now, all the regional labs have the capacity for microbiology, and we have a specimen referral and transportation network where these regional labs actually can act as hubs so that they can test for lower level labs. It is just something that is picking up. Utilization of microbiology services that are now available is still a challenge, with many healthcare workers kind of still just giving antibiotics empirically, and they are not optimally utilizing the labs adequately, but we are trying to do diagnostic stewardship to promote utilization of these labs. So these were initially, these hubs where the transportation system was developed mainly for HIV early infant diagnosis, but we are taking advantage of it to provide microbiology services. Surveillance of consumption and use. We are currently doing point prevalence surveys of use in hospitals, and this is some of a breakdown of the use of antibiotics. The regions in red, the prevalence of antibiotic use was greater than 60% in the most recent national survey, national point prevalence surveys in the hospitals. And to the right, there's a dashboard. So once the data is entered, it is available on a dashboard, and people can see the utilization, the use of antibiotics, and appropriate interventions can be taken. Surveillance data, this is a bit of surveillance data that may be small for you to see, but our most common pathogen in most of the our clinical space, our most common pathogen is usually E. coli. We have Klebsiella pneumonia as well, Staph aureus, Salmonella, incidentally, for which a lot of antibiotics are given. Typhoid fever, many of the febrile illnesses are often considered typhoid. We hardly ever isolate typhoid in our blood cultures. It is not common at all, but still it is probably one of the leading drivers for antibiotic use. And that is something we really need to intervene upon. But we can see, I think similar to what Xavier was saying, ceftriaxone incidentally is I think one of the most commonly prescribed antibiotics, but resistance to it is above 70. I think 70 may be actually a liberal. When you go into hospitals, when you go into, say, inpatients, it's much higher. It's probably above 80% resistance among the gram-negative rods. So that's an issue for consideration. When we look at that was data previously, this is data from the regional referral hospitals. At national referral hospitals, we can see that resistance to third-generation cephalosporin probably is about 90% among the gram-negative rods. Carbapenem resistance, which here is not very high. It was about 2% for E. coli. In our intensive care units, it exceeds 30%, which is not probably surprising. And it can go up to 70% for Acinetobacter. There is a bit of resistance to colistin. In animal health, incidentally, we don't have a lot of diagnostic animal labs, and a lot of the data is maybe surveillance from fecal carriage, and not necessarily from sick animals, but from those E. coli, resistance to the third-generation cephalosporins and the carbapenems is not very high. It is rather low. I don't have the figure here. It wasn't put in this slide, but it is not very high. But the cotrimoxazole and tetracycline, it is much higher. In the environment, we isolate some E. coli from water sources, various water sources, and resistance to cotrimoxazole quite high. Resistance to the third generation, there is some modest resistance, moderate resistance to third generation cephalosporins among those isolates. We've not done genomics yet to establish whether, the relatedness between these organisms. We are beginning some initial steps towards genomics. I don't know if this roadmap has been published yet, but the Africa CDC map for genomic surveillance of antimicrobial resistance in Africa, and it takes consideration of major use cases, particularly neonatal sepsis and hospital-acquired infections, invasive salmonellosis, and One Health surveillance using the tricycle framework. Those are the major use cases for genomic surveillance recommended by the Africa CDC framework. I don't know if it has been published, but I was part of the team that. So we've not yet started a lot. There are studies here and there, but we are starting. And one of our students in ADAPT, Alison, with us here, actually leads the lab, and his PhD program will propel our ability to do genomic surveillance at the National Reference Lab. So he's doing genomics of Acinetobacter, and that will help propel our surveillance, genomics, incorporating genomics in our surveillance programs. Stewardship guidelines have been updated, and yeah, currently, like I think Xavier also mentioned, we have started the Teach AMS program. We are among those who are doing the Teach AMS program, which trains people in issues related to antimicrobial stewardship, optimal antimicrobial use, and that is one of our major training programs. THET is also a major partner that we work with, the THET program that is doing a lot of antimicrobial stewardship, supporting us do antimicrobial stewardship in various hospitals. Our national medical stores also has a number of pharmacists who are supporting hospitals to participate in the antimicrobial use and consumption surveillance and surveys and surveillance, and also train them on issues of antimicrobial stewardship. The National Drug Authority, ensuring that quality of medicines, testing the medicines and for quality, and also promoting policies that will improve access on antimicrobial use. For example, there are policies that promote production, in-country production of antimicrobials in Uganda. Infection prevention and control is central. We've updated the guidelines on infection prevention and control. Infection prevention and control is one of our major challenges. And one of those is that the healthcare system has a lot of challenges, inadequate number of healthcare workers. So implementation of infection prevention and control in healthcare facilities can be a challenge. On the farms, people often see it as costly, and our colleagues in MAIF are trying to convince the farmers and small-scale farmers that it is actually cost-effective to implement infection prevention and control on their farms. Research, this was a summary of research activities among East African countries, publications in the last about 15 years. Ethiopia had lots of publications. We and other colleagues were lagging behind. Some modest number of publications. Uganda, I think, is this line. So we need to actually pull up our socks as far as research in AMR is concerned. Funding for research in AMR, a lot of it was international. That's double-edged. Maybe more funds, the research may be higher quality, but there's a risk to international funding at the moment. So countries we need to work hard on that. So the challenges, the limited resource allocation for AMR, trying to advocate more, the regulatory framework, lots of policies have been passed, but enforcing, for example, enforcing the regulation of use is still a challenge. antibiotics are still commonly available in the drugstores and pharmacies. The weak health care system that I've mentioned, making implementation of some of these a challenge, inadequate diagnostic capacity and stewardship. We are improving laboratory capacity, but many challenges remain. Microbiology, the inherent challenges in microbiology, the delays and clinicians getting frustrated by delays in results. Animal health and environment are probably in a worse situation than we are. So we are trying to make sure that we improve the diagnostic capacity and diagnostic stewardship to improve utilization of the labs. So the WASH, we need to improve our WASH. Inadequate locally generated research data, as I've mentioned. Outbreaks have been a challenge. We've had COVID, and in Uganda we've had multiple outbreaks of viral hemorrhagic fevers like Ebola, although we've actually been able to contain them. And this has been double-edged. While it has diverted us a lot from infection prevention, from AMR activities, it has helped put infection prevention and control at the fore. So, and then we need to strengthen the One Healthness of our interventions. For example, making sure that the surveillance data talks from one area talks to the other. So thank you very much. Our partnerships have been key. Thank you.
Wow, Henry, on time. Yeah, really good. Thank you very much. So, everyone, we will move to the next part. Before we move to the next part, I ask the people to bring the chairs. And I ask the people sitting behind to open the curtain, because now the sun is gone from the east side, and now we will move to the other side. So I think we need to just open the curtain to bring more light into the room. Yeah, this is very important. And I will ask now everyone, please stand and relax yourself a little bit, because I think it's we'll have another 1 hour to go. So you need to... Why nobody is standing? You need to stand, please, everyone. Stand, everyone, stand. Yeah, and we need to bring the adapt dance, you know? Adapt dance, yeah, please, you need to stand. It will have your muscle will break now, yeah? So you need to stand, please, yeah? Okay, that's good. Okay, now we will move to the next panelist. So I will ask Dr. Damali Nakanjaku to come to the front. Yeah, you are in the panel list, Dr. Damali. Yes. No, yes, no problem. Just, he can. Dr. Henry, please come in the front. So we are in the panel list. Dr. Azuma, please come to the panel list, please. And Dr. Akosua, please come to the panel list. Is wrong, yeah? I'm so sorry. I will tell you Dr. A, so it will be difficult. Yeah. So please. Yeah, you just please take any seats. So we'll close this one, so don't worry. No, just stay. We don't need this anymore, yeah, so. Yes. So, I think we have heard a lot about many stuff in the presentation, and I will start actually. Let us do it like this again. I think it's very important. Can you just come a little bit here? So I think we know most of the people, but let us make a short round of introduction, the name and the function very fast, that everybody again recognize the people sitting on the chairs. So we have another mic. So I will have only one mic because I will speak a lot. So Henry, you just speak, but
Oh, thank you. I hope you're not bored of my voice. I'm Henry Kajumbula. I work with Makerere University and I chair the Uganda National AMR subcommittee. I'm a clinical microbiologist.
Damarina Kanjako, Professor of Medicine, intern specialist and ADAPT Director. Thank you.
I'm Dr. Akusia Omari Sasu, the Kumasi Metro Health Director, and I'm a public health physician specialist.
Thank you very much. My name is Dr. Azuma Abdul, public health physician specialist. I coordinate all and elsewhere is getting the environmental sector to play their role, because for the environment, it's difficult to link it up, especially when you are looking at health-related activities. You are talking about human health. The animal will get sick. You will definitely see the physical signs of the animal being sick. The human beings, when they consume that, will get sick. You will see the signs and symptoms. But in the environment, what would you see? So sometimes it's difficult to get that link. And also, if you look at the environmental sector in Ghana, it is spread across multiple ministries, agencies, and institutions. At our last count, we had about 19 ministries, agencies, and institutions that had what? Environmental component of it. So to even identify which sector to work with when it comes to the environmental sector is difficult. So for us, we do it on a case-by-case basis. So if you look at the cholera outbreak that we are dealing with, for the environmental side, we are using the environmental health officers who are at what? The local government ministry. When you look at some that involves contamination of water and all that, we zoom into what? The EPA. That is where we have the environmental aspect. So for us, the human health and the animal health, our relationship has been fostered with working together for a long time. But the main challenge is getting the environmental sector to play a key role. And I'm hoping that in the future we'll be able to find a way that will get all the three sectors to play a role. Because for us, the cholera outbreak we are having now in the country since October, the main drivers has been water and sanitation. But now the water and sanitation, how are you going to get the environment to play what? That critical role. But then, now we've seen that political leadership, especially at the local level, because at the local level, all the sectors are under either the regional minister. We can use those political leadership to get the environment to play a strong role. At the local level, it will work. At the national level, will be what? Very, very, very difficult because of the fragmentations that we have. So for us, that is our...
So mostly as the resources and sharing resources. So resources will never be, all available. So mostly you have to combine to be able to deal with all issues. What mostly is sharing information. So if people are aware about MR, then when you meet as a group, you can be talking about HIV or TB, then you slot it in. For TB, we know multi-drug resistant tuberculosis is there. So they know that if you don't treat a susceptible well, or they don't complete their regimen, it could lead to drug resistance.
implementation of this plan and what is missing and how we can support pushing forward the implementation. Because plans are there, we know that. If you implement it, we will not have problems, hopefully. But what, from your point of view, what is the problems for implementation?
Yeah, so thank you very much. The end-term assessment report of the implementation of the, and we knew from the beginning how I'm on board to support. In our budgeting system, we have donor support, and so we need the government's funding should be also be released. But this normally is difficult to be released, looking at the economic situation we were facing. So whatever the partners actually gave us, we make use of them. That is the Fleming Fund gave us money, and that's what was heavily invested in the surveillance system. Then how are we addressing this challenge issue with funding challenges? We said that there's the need to mainstream our NAP into sector action plan. Every ministry or every department, even at the hospital setting, we do yearly budgeting. So the activities in the National Action Plan that pertains or that concern a particular sector, you put it in your action plan for the year, the ensuing year, so that if the budget is approved and there's some money approved, there will be some funding for AMR. As an example, 2024, we mainstream at the national level, and we got funding from the central government to do the revision of the standard treatment guideline using the data we have. And likewise, the environment to have done the same, Ministry of Environment, they've also done the same. So we believe that mainstreaming the activity into our sector activities will give us some funding. And then the other challenges about some stakeholders feel they were left.
I give them the information.
So the self-directive learning, it's a very important tool, and I will ask the young generation, so prepare your answer, but I will take also another part of education, because usually we focus on the education, schools, and then university, and then if you graduated and become a medical doctor or a veterinarian or a health officer, you forget that you need to be further educated. And this is a very big challenge, and I think Afra Health, you are doing a great job in educating medical doctors and people working in the medical field after graduation, and you also did a very nice training on the first day on antimicrobial stewardship here. So from Georgina, from your experience in Afra Health, how challenging to convince people already become an adult, in our opinion, to sit on the table and try to learn new stuff. So what do you think about this? I have the mic, don't worry.
Thank you very much, Ahmed. So one of the things that we are doing, because it's difficult, I myself, it's difficult for me, so I put myself in their shoes, is where you have programs that allow people to learn at their own pace. So they keep learning, but at their own pace. So we have programs on our learning management system where people register and then they do it at their own pace. And currently the program is designed such that there are modules, 24 modules. That example is a Stripe HIV course that we do for pre and post service health professionals. So you can do one module and get a certificate. So previously, you have to finish all before you could get a certificate. And it was difficult for people to finish all. That was 22. So finishing one, you get a certificate. So you pick the one that you want to do and get it. And so as adults, if you are able to do self-paced learning, that also helps us a lot. So at our own instance, you just have the time to do it. Not a very long one, too. And on the course, it should also be something that is interactive. In a way, I did a global health program, which Stellenbosch University does it, and within that, it's you can study on your own and also interact with other people within the forum. So it is not just you go and read, you answer and come back, but there is a forum. You can post a question. They can also post a question. Other people can discuss. So these are ways that you can encourage adults to learn. And that is what AfriHealth is doing.
Yeah, this is really, really good, because we need to have this post-graduation training, and this is one of the important. I will ask now the young generation, what you miss in the current education system as a master and PhD? What you would like to see in order to be, especially, and this is very important here, we're speaking about with policymaker, engagement with the ministry, engagement with the people which can do the implementation. What do you think it's missing? So anybody would like to say something before I really select one? And this will be very difficult. Yeah? So you need to think. George, I will come to you. Don't worry. You are in the next, in my agenda. But you are in the level of the adult, very, very adult, yeah. So I need to ask you, Inas, you can tell me, you know, you were thinking the whole time. What you miss if you are a PhD student? What you miss really in the field of education, or what really you miss in your qualification to be a doctor in the future?
Actually, actually, I'm not missing anything. I have I have a good guidance to do everything. They really helped me a lot to do my PhD. So just we have we running with the time that we have in a short time. So we have to do a lot of things, and maybe the AI help us a lot for this. So thanks a lot.
So AI, yeah, this is a very important part. We will speak about this in a minute. But Patrick, what do you think? You are a young researcher in Uganda.
Yes, thank you so much. Actually, as far as not learning and knowledge is concerned, I'm not missing much. But I feel like, as Professor Double normally said, we need more emphasis on how we can translate what we do in the lab to the community. How can what I do in the lab, how can it impact the community? How can I translate what I do in the lab to the community benefit? That's what I feel like should be more emphasized, more in the young community. Thank you.
I will hear from Ghana, from Luis. He's sitting behind there and hiding, and now he's laughing. Yeah. So what's your thought on that?
Okay, thank you for the question. So apparently, if I take KCCR for instance, from time to time we get visitors, let's say from Ministry of Health or maybe from, let's say, the German embassy coming around, and we get the opportunity for instance, an example, I had the opportunity to demonstrate how the mobile lab works. So they had a first-hand experience of what it does. I had the opportunity to also relate to them what we are doing and how it can fit into our routine health system. So I think when we are able to, maybe once in a while, have these policy makers or other influential people come around to see what we actually do and not just publish the paper, but they are part of the whole development process. And one more thing too could be, let's say, for the young generation, there's a lot of people on TikTok, influencers and all that. If we could liaise with them and get, rather than just putting posts and other stuff, get them to post about science a bit and these issues that's going on, I think that can go a long way to make our work meaningful and more impactful in the society. Thank you.
So that's been two important points: dissemination plans with the policymaker, and this is one of the meetings, so you need to engage. And dissemination, it's always very important, like new diagnostic or something like that. This is very important. And using influencer and social media, but you can act as an influencer. You are handsome. You can really start a business. This is very good. You will get more money than the PhD, by the way. So try to do it. Try to do it. And moving from young generation, I really keep this note to the middle. We have now, and I will ask all of you how this will affect, because Dr. Sofer had said very important thing is funding. And now, in funding, we have USAID. There is some people that said, okay, we don't push money anymore. And then the WHO has really pushing hard in the last 5-6 years, country ownership. And we have discussed this one now. Even now in discussion in Germany, how you can make the collaboration based on sharing costs, not like one person really pushing money and the other just receiving the money. So sharing cost, country ownership, decrease the funding, how these stuff really affecting what you are doing and how you really what is behind the scene going that the country push the fund. Because if you see, we didn't come to this area, but if we discussed with Henry yesterday also that how much really research fund are pushed from the government, and if you see, it's very, 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 very little. If you ask the government, I will need to buy a car for the field, you go give it the car, but if you tell them I need to something in the lab, you get no money. So, yeah, so, George, it is coming. Yeah, so I need to hear from all of you, actually, a few words about funding and how this is challenging and how you see the solution in 1 minute every person. So I start with here from the right-hand side, please.
Yes, so the issue about funding, we look at it as the advocacy level, that we need data to explain to the decision makers, especially the Minister of Finance, that is where the decision is taken. to know why they need to increase allocation to that. For instance, when the U.S. government withdraw the aid, the President of the Republic ordered immediately the finance minister to look for funding to plug some of the gaps that the withdrawal is causing. And so we also need to advocate for that. And for me, where I sit, for AMR intervention that we have, at the facility level, the hospital levels, there is an opportunity to implement the stewardship programs from the funding that you generate, because the internally generated funds from at the hospital levels is still government funding. So you still have to budget, get approval before you can spend it. So that is where we are advocating for mainstreaming. The national one that we have to do, then we then have to put in the budget and then advocate for it to be given. Sometimes they will approve the budget, but releasing the money is an issue. Yes, that has been an issue all the time. They see the justification for it, but the fund is not there to allocate. And we just have to continue struggling, advocating for the fund to be released.
Dr. Azuma, what do you...
Yes, okay, thank you very much. I think I had wanted to add something to the community engagement bit, which is more of a practical experience. The cholera outbreak, there was one district that had it in the early part of August, then declared it over in September using laboratory evidence. They were getting multiple negative samples. Then, after a few weeks, acute watery diarrhea cases are going up. Culture in the lab is negative. Then what happens? We are all panicking. Are we dealing with something else? Is it cholera or is something else? Then we went to do a detailed investigation, went to the communities, house to house, to do active case search. Everybody, majority of people would have had an episode of acute watery diarrhea, and guess what they were doing? Oh, what were they doing? They were all taking doxycycline. Because in the earlier outbreak, those who went to the hospital, they gave them doxycycle. So now when you also have acute watery diarrhea, they become prescribers. They give you what? Doxycycline. So everybody was taking doxycycline. Those who come to the hospital, you take culture samples to the lab, it comes out what? Negative. That is how, if we don't get the communities engaged and empowered, they are actually going to confuse our science. Because, yes, they are having vibrio cholerae, but they are taking doxy. So you go to the lab, you think this person hasn't taken antibiotics. So the interpretation of even the results, because if the history that the person has taken antibiotics is there, the interpretation of that results, you would want to try and look at it in a certain way. So for the funding, for us, honestly speaking, I think there is a little disconnect between AMR activities and the biggest service provider, which is the Ghana Health Service. For us at the Public Health Division that does surveillance for priority diseases in the country, the picture is more like it's a lab. We've featured it as a lab thing. But if you look at it, it's not lab. From what we saw during the cholera outbreak, it brought everybody's mind that no, if AMR resistant to antibiotics in the communities, if we don't take time, if we don't take it serious, it's going to impact on the kind of results that we have for our surveillance activities. And you know surveillance is just information for action. So if the information we are getting is tainted because of people in the community are taking antibiotics and all that, our work is going to be impacted negatively. And then for the funding, we were fortunate to get the second round of the pandemic fund. Ghana was part of the countries to have been successful in that round. Most of the AMR activities are captured under a lab. Interesting enough, they were captured under lab, so I'm sure it was part of that mindset that we were working with. But when you look at the animal sector, the kind of activities that they had put there, Dr. Sasu was part of those who were helping us write. Is it farm something? The samples they take from the farm for the testing of antimicrobials and all that is captured into it. So I'm sure, as he said, we may have some challenges because we are not able to translate our data into the kind of information or the languages, as Prof said, the politicians understand. Because for the politicians, it's about the masses. So how does this AMR data we are having affect the masses? How will it get me votes from the next election? That's the truth. How will it get me vote from the next elections? So I think with the data we are having, if we are able to do some form of modeling, some predictive modeling, we can be able to predict the impact of abuse of antibiotics or antimicrobial agents in general on the country and how much it will cost. Because usually for us, the issue is that we say, okay, we don't cost. So nobody is even able to quantify how much the burden is. We put, for scientists, we put out the numbers. But the other people, we need to quantify it into financial terms for them to be able to understand at that their level, to be able to support us. I know the withdrawal will affect some of our activities, but we are hoping that with the kind of stewardship programs that they've put in place, the ownership and all that, we should be able to weave our way around all that challenges. Thank you.
Dr. A, so funding is a big issue if you are the director, yeah?
All right. So if you move down to the facility level, they generate, the hospitals and the other teaching, they generate funds. So mostly if you are here, there's a matter of priority and what the data speaks so that they can put funds into those activities. And then there are other organizations in every district or community we can seek funding. If we know this funding line is not coming, depends on how you package it. I know there are pharmaceuticals, others who might be interested. Depending on what new drugs they are bringing. If they now there's the pattern we are having. So if they can produce these antibiotics that we need to use, because looking at the data, it's really worrying if about most of the antibiotics we are using are resistant to the, means we need higher ones. And this goes to the pharmaceuticals, which can support. So there are other areas, I think, seeking funding from them can help support what we are doing. So for me, I think, though funding is a challenge, it depends on where we are looking for it and how we package the story to do it. At the facility levels, they generate funds, so they can be able to support these activities. Thank you.
Thank you. Dr. Abel, you are working a lot with also USA and other funding. So what's the challenges now, especially for Uganda?
Well, I would say that the biggest challenge about funding and who gives the funding, again, is understanding why we are getting the funding, because knowledge is power. And who is advocating for the funding? Most of the time, we have had technical advisory groups, they're the ones advocating for the funding. We are groups of scientists, we are the ones advocating for the funding. But in any country, if the community advisory groups are the ones advocating for the funding, they're the ones going to parliament, then that funding will be given, will be allocated to funding. But the universities, the technical advisory groups, the WHO, we are the ones telling countries to have funding. So we need to educate our communities and engage with them, and they understand why we need the funding, and they are the ones who talk to the politicians, and the politicians trust them because they want their votes. But they don't know what to ask for. But what they ask for, they get from their politicians. So we need to invest more in educating the community. The scientists, if we are very busy, we need to strategically get a dissemination strategy to make sure that the community people receive the information and they understand how to advocate for their own funding. You remember during COVID, the vaccine issue. If the scientists sit here and say, okay, everybody needs a vaccine for COVID, you will take it to the community and the community won't receive it. So how will the community understand that really we need a vaccine? So we need some of those practical examples. You tell countries you need to fund your health. When COVID came here and there was no funding, who was funding the COVID interventions in the countries? Countries funded their own COVID interventions.
Yeah, you're right. Henry, what's your thought? You spoke about funder, and you have a list of funder, so you are a rich guy, you think, yeah?
Thank you very much. As Professor Damali said, if she wasn't my boss, I would have said she stole my thunder. But, but yeah, I think the onus is really on us to make a case for local funding. We know the purse is small, but I think we really need to make a case and demonstrate what can be done with the available resources, what could contribute to research and what. There are a number of people, of very rich people within the countries, the private sector, the government itself has lots of money, though usually not enough. But I think if it's really up to us to make a very good case on how this funding, how much they could contribute and demonstrate what it could do. How is it going to change things? What's the cost effectiveness of making a case? How cost effective is it allocating those resources into what? Into these research activities. What are the best models of utilizing the resources that are available for research? Private sector, pharmaceutical, as other people have already mentioned. So I think really we need to go back, sit down and come back. The other thing is identifying the research priorities. Okay, but the research priorities, I don't know if all countries have done that, identifying research priorities in the various components, for example, AMR or what. I think those may be ways that we could be eventually able to advocate for better funding. Thank you.
So I will move to Kamal, because Kamal will move from funding, especially with a lot of difficulties of funding and ownership and cost. I will move to Kamal because Kamal did a very important part of ADAPT network, which testing local disinfection and how local disinfection can really, instead of really implementing using an antibiotic when the problem happens, how we can ensure biosecurity at the farm level to avoid spread of antibiotic and so antimicrobial resistance bacteria or others, and also have this local disinfection. What's your challenge actually, Kamal, to collect? Kamal has created a very nice app, he will represent it tomorrow, about local disinfection in the involved country and how we can use it. So what's the challenges in collecting this information and how important this part of ADAPT network?
Thank you very much, Ahmed, because I think the speakers, when they presented their work here, they have spoken about prevention control, infection control and prevention. And one of the, I think one of the measures that you have to do is to prevent infection. And disinfection, one of the most widely practiced in healthcare systems, so that to prevent infection in every aspect, in the outpatient clinic or in the theater or wherever. And the challenge is always how can you get rid of these antimicrobial resistant organisms when they are in the system, for example, in the healthcare system or even in the environment. And using disinfectants is widely practiced, of course. in the healthcare systems for the human. In the veterinary healthcare system is I can identify because I can measure based on my experience in the Sudan is the annual production, especially in the poultry sector, because they have to use in every batch a new disinfection process to introduce a new batch for birds for example, for the second or collection of the information regarding these disinfectants was extremely difficult for me because of many things. The group are not always engaged in such activities, also to be in direct touch to what is actually done in reality. For example, because I am focusing on the veterinary field, getting information is somewhat difficult. For example, I tried to collect some information from the Sudan. I always say what I face in the Sudan is always similar to what my colleagues face in other countries. We are almost the same. And one of my students insisted to one of her students, because I have to go to the veterinary pharmacist to collect data about what is available from disinfectants and other things. And he found difficulties to get information. Why? Because those veterinarians who are engaged in veterinary market of, for example, drugs and everything, they say, yeah, you are collecting information to compete us, because they think that when he gets the information, then he will have good knowledge about the market of veterinary drugs and disinfectants, and then he goes to China or India, and then he bring whatever they can. So this is, I think it is one of the challenges. Always the people, and this is one of the points that we are at least two different communities. In the science, we look from only one point of view. The others look to the other without any thinking about the science. They only think that business, money, and some. They don't think they are doing science for their own benefit. So this is one of the challenges. The other thing is that yes, oh, sorry, yes, okay. The other thing is that okay, 1 minute. The other thing is that collection of or to collect information from the internet or online available data is extremely difficult, because we have very small contribution in the knowledge in the web, in Africa especially. So I think this is a
little contribution, building trust. I will come to you, but I need to take, we have limited time. I need to take, we have another important part of ADAPT network, which is co-infection, because the people use always the AMR, it's happening like this, and there is an AMR, but what George and his team together with Sheila and DRC discovered, we have a lot of parasitic infection together with AMR detected in animal field. How you can tell us what is taking a full picture of co-infection is very important if you study AMR.
Yeah. Well, it is very important because we have heard today that we continue to misuse antibiotics. Most of the time, what we use antibiotics for does not even exist. In my country, for example, if you want to scare anybody, you just say that that person has typhoid. And anybody who has high blood, anybody who has high body temperature, is presumed to have typhoid. That is the general street on the street. And then people know how delicate typhoid is. So they are often exploited, money from them. 70 to sometimes 100% don't have typhoid. Now that means that they have some other reasons to have caused this problem for them. Oftentimes it is due to some other kind of infections, because those infections have symptoms that are overlapping. So which is
similarities are always, we are struggling with a lot of issues, and everybody has a different priority. So interact among us to understand each other better, because I think we always have a little bit step back from our own priority and so see how can we interact, how can we collaborate, how can we improve, because what we have seen here is there are a lot of good ideas, there's a lot of knowledge, and there's a huge way to put it into practice at the local level. So we have to involve all these different people, and everybody has to understand the role. So, and I think this is the same also in Germany. Maybe we have other opportunities, but still it depends so much that the people understand what exactly could be the next step. Well, how can we do the next step? How can we improve a little bit? And how do ourselves and the others benefit on the long term? And this applies to everything we are discussing here. So, thanks.
Thank you. So collecting more information, we have a lot of similarities, and one of the big outcome of ADAPT is also the antimicrobial stewardship, which the Ethiopian team are working, led by Professor Yimtu, and I would like to hear from you, because the base on ADAPT is, because sometimes when you do an antimicrobial stewardship program, you do it based on the books. But what's happening in ADAPT, we do an antimicrobial stewardship based on the outcome from the network, for the network, and how really you start with a systematic review, what's happening on this antimicrobial stewardship in the continent, and you have some challenges I need to tell us about. Thank you.
Thank you so much. I think one of the results, anticipated results of this consortium is antimicrobial stewardship training program, which, as was said, will we will triangulate all the data from all the tasks, and then we have a survey of what's already there in the different countries, which we have analyzed at least partially, which we'll present tomorrow, and then we are doing a systematic review, and then we are going to develop antimicrobial stewardship that will hopefully reach, like Damali was saying, even our target group will be different in this. It's not about only professionals. We are talking about people at the, at the grassroots. So, and then the continuity of that training program also will be very important, because we are having Havre Health, which have their own platform. When we have developed already the antimicrobial stewardship program, it will be, the continuity will be ensured after the 5-year lifetime of this project. So I think, and the important thing is that all the partners are involved in this task. So we are very happy to lead that, and hopefully we'll have at the end a very good outcome. Thank you.
Thank you very much. So this is very important, but sustainability after the project end is one of the key issues. But I will hear from Sheikh, Institute Pasteur de Dakar, because they have a very interesting project to sequence at the genomic level AMR isolate from several sub-Saharan Africa country, and you have a big project funded in order to do this genomic surveillance. So you can tell us about your experience and this program.
Okay, thank you, Ahmed. As you said, this initiative is funded by Fleming Fund to support African initiative to better understand what is the dynamic of evolution of AMR. And this is led locally by 2 institutes, IPD and 3 institutes, IPD, Negotiate, and the other institute, I think it's in South Africa. Right. for this initiative, I think, as you know, when you look at the map across the world, we have many data from the different countries, except in Africa, and this gap should be covered. That's why we get this initiative, and right now we support many African countries. And what we are discovering is that across the different sectors like animal health, human health, and environmental health, we can see the dynamic of exchange between the different sectors. That's why it's very good to adapt to One Health approach. And then by this project, through Adapt initiative, I think we are one of the first consortium who are dealing this project, and maybe next step will be to further investigate it based on the preliminary data generated by this project. Thank you.
Yeah, thank you a lot for this initiative and collecting genomic data and sterilization of data in Africa. We finished now on time, which is really good, but before I finish, I need from the panelists here only one sentence. What is our, like you said, we need to have a policy brief of this meeting, and I need from the panelists here, based on this very nice discussion, just one sentence. It's very difficult because usually I will tell you, I will write to you a long letter because I don't have time to write a short one. So, so think about it. Yeah, so we need one sentence. What is our take-home message in order to put it on our policy brief, which Dr. Michael Frembong will prepare as an outcome of this meeting and present it to the Ministry of Health. So I need to hear, I will start hearing from you this time because I see you are writing a lot. So I see from this side. So I think Dr. Sobe, he was preparing already, but I will move it to the other side, and I will hear from you, Henrik, first. What do you think the main key message to the policymaker? And we move forward, yes.
I think the message we should convey is about the funding for AMR and for research. It should be about mobilizing funding for research for AMR and One Health.
Funding, it's a very important issue. Damali.
Yeah, for me, the message would need to convey is that antimicrobial resistance and antimicrobial stewardship is a community problem. So it needs a community solution. So let the community set themselves up. We'll be there to assist them to come up with the solutions, which includes the education, the funding. All that has to come from the community. It is no longer a doctor's problem.
Yes, community engagement, one of the key. Yes, Dr. A.
All right. The take home will be here is sharing information.
Okay.
Across the various sectors, and getting the information to the community so that we own it and set it as a priority for us to work on it.
Information sharing and also information standardization. This is very important. Okay, thank you very much.
Thank you. It's difficult for me, but
it's one sentence.
Yes, I think we've agreed that local ownership of AMR should be very, very key. We should move AMR from the lab to the doorsteps of the people.
Thank you. Doorstep of the people. Very good saying. We end with you, so you are...
Yes, so mine, which also is not in the NAP, is the AMR research agenda for the country. If you ask government to set up a research funding, they'll ask you, what do you want me to fund? So we need to have that, which is not in our current system, so we'll work with the nursery research agenda on AMR to drive us to the future.
There you go. So research agenda, this is a very, very important part. So we need to work on that, and I think we have many researchers to put some of this agenda and on the table of you. So thank you very much for the panelists. It was really a very nice engagement discussion. We thank you a lot for coming long distance, short distance.